Hello everyone and welcome back. Today we will be discussing another very important topic, which is your acute rheumatic fever. Okay. So what is acute rheumatic fever? So rheumatic fever is basically a multi-system disorder which is characterized by autoimmune reaction to what? Autoimmune reaction to group A streptococcal pharyngitis. Okay. So group A streptococcal pharyngitis. We all know that streptococcal pharyngitis is a relatively benign condition. But in younger children, sometimes there can be an autoimmune disease which is triggered because of a reaction to these antigens which are produced by the group A streptococci. Right. So group A streptococcal upper respiratory tract infections is the most common trigger. But sometimes there can be a skin infection also, which can trigger this multi-system autoimmune disorder, which we call as your acute rheumatic fever. Fine. So what is the age at which this rheumatic fever is most common? It is most common in the age group of 5 to 15 years. Okay. So this is most common in the age group of 5 to 15 years. It has been found to have a higher female predisposition. Okay. Now, in adolescence, there is an increased risk of recurrence. Okay. Fine. What are the risk factors? So, rheumatic fever is considered to be a disease of the poor, right? So, poor sanitary conditions, overcrowding, slum dwelling, poverty, all of it has considered to be a risk factor for the development of rheumatic fever. Many of the patients also avoid treatment of pharyngitis on time. If you avoid treatment of pharyngitis on time, or there has been multiple episodes and failure of treatment, then this itself is a risk factor for the development of acute rheumatic fever. What is the pathogenesis? Right? So there is exposure to your group A streptococci. Once there is exposure to the group A streptococci, the host itself has some risk factors. So, based on previous studies, we have found that there are some HLA associations associated with this rheumatic fever, which includes HLA-DR4 and HLA-DR7 positivity. So, with these risk factors, there is an immune response which is generated. What is the immune response? There are antibodies to certain antigens on the streptococci. So, there are antibodies to some antigens on the streptococci, which are predominantly what we call as your M proteins. But these antibodies inadvertently cross-react. They cross-react against the cardiac myocytes as well. So, these antibodies inadvertently cross-react to the cardiac myocytes as well, and that is how your rheumatic fever happens. Okay. So, how do you diagnose rheumatic fever? The criteria which is now used is your modified Jones criteria, which was revised in 2014. So, this is your modified Jones criteria. So, they have categorized the clinical manifestations into major and minor criteria based on low risk population and high risk population. Okay. So, the high risk population are usually the developing countries such as India, and the others are the low risk population. So, how are you defining a high risk and a low risk population? So, a low risk population is defined as where the incidence is less than 2 per 100,000 population and the prevalence. This is your incidence and the prevalence is less than 1 per 1000 population. Okay. So, in a low risk population, how do you diagnose it? For the initial episode of acute rheumatic fever, you require two major criteria or one major plus two minor criteria. This is for the diagnosis of acute rheumatic fever first episode. So, presence of two major criteria itself will diagnose as acute rheumatic fever, or presence of one major and two minor criteria. But for recurrent rheumatic fever, you take two major criteria, or you take one major, two minor, or even if all three minor criteria are present, then you can take it as a recurrent rheumatic fever. So, in low risk populations, how is the major criteria different from that in a high risk population? So, we know that the five major points which are present in the Jones criteria, we have carditis, polyarthritis, chorea, erythema marginatum and subcutaneous nodules. We will be looking at each of this separately, but you remember the five: carditis, erythema marginatum, subcutaneous nodules, chorea and arthritis. But here you take only polyarthritis, whereas in a high risk group, monoarthritis or polyarthralgia, monoarthritis and polyarthralgia is also taken as a major criteria, which is not so in a low risk population. So that is one difference that you have to remember. Monoarthritis or polyarthralgia is also taken as a major criteria in high risk populations, but this is not there in your low risk population. Okay. Now, when you look at the minor criteria, so you can see polyarthralgia is a minor criteria in low risk populations. Then monoarthralgia is a minor criteria in high risk group. Okay. Now, there is a difference in the fever and ESR cutoff as well. So, the fever cutoff is taken as more than 38.5 degrees Celsius in a low risk, whereas the fever is taken as a cutoff of more than 38 in a low risk group. Then ESR cutoff is also different. It is more than 60 in a low risk group, whereas more than 30 itself is considered to be a positive criteria amongst the minor criteria for high risk population. Apart from that, prolonged PR interval is considered to be an ECG change suggestive of acute rheumatic fever. Fine. So, this is about what are the differences in the Jones criteria for the high risk population as well as a low risk population. What are the differences in your Jones criteria for high risk population as well as a low risk population. Now let us look at what are the clinical features. So, what are the clinical features? First one, let us look at carditis. So, what is the pathology here? You have a pancarditis. Pancarditis means what? All the layers of the heart are involved. And what name is given to this? This is called as the bread and butter appearance. This is called as the bread and butter appearance. Okay. This is called as the bread and butter appearance. So, pancarditis means what? What will be the features of all of this? You have endocarditis. How do you detect endocarditis? You can have a murmur. Rheumatic valvulitis itself can cause a murmur. The murmur which is seen there is known as your MDM murmur, which is your Carey-Coombs murmur. Pericarditis, how will you identify? You can have a pericardial friction rub. Myocarditis, how will you identify? There will be symptoms of heart failure. You can have an S3, you can have an S4, you can have pleural edema, you can have orthopnea. So, that is how you identify which layer of the heart is involved and how carditis and rheumatic fever presents. So, if you have severe carditis, the treatment is by steroids. You give it at a dose of 2 mg per kg per day for 3 weeks and you slowly taper it over 9 weeks. Okay, you slowly taper it over 9 weeks. Then, arthritis. What are the characteristic features of arthritis and rheumatic fever? It is a migratory polyarthritis. What is the meaning of that? It means that the one joint is swollen and it completely settles down and then moves to the next joint. And the child is sick and the arthritis is very, very painful. It requires to be carried even to the bathroom or for your regular activities. But this arthritis is extremely responsive to aspirin and NSAIDs. This arthritis is very well responsive to aspirin and NSAIDs. Fine. The next, we have your subcutaneous nodules. Okay, we have your subcutaneous nodules. Where all do you find these nodules? These are pea-shaped nodules. As the name suggests, in the subcutaneous plane. You can find it, for example, over the vertebrae. You can find it over the extensor aspects such as in the elbow. Okay. So, these are found in the vertebrae. They can be found in the occiput. They can be found in the elbow as well. And generally, they are transient. They are transient. Okay. Fine. So, that is about the treatment of subcutaneous nodules. Now, let us look at the next one, which is your chorea. The next manifestation is your chorea. What is a chorea? Chorea is a rapid, semi or quasi-purposeful movement, predominantly involving the distal arms or feet. So, this is a dance-like movement. Okay. So, what are the other clinical signs that you can find associated with chorea? You have something called as the darting tongue or the jack in the box phenomenon. So, in your darting tongue or jack in the box phenomenon, the tongue protrudes in and out. Apart from that, you can have something called as the milkmaid grip. Milkmaid grip means what? When you hold the patient's hand, they have writhing movements like this, and this is what we call as the milkmaid grip. Now, chorea can be a late manifestation. Many a times the rheumatic fever settles down and the chorea can happen. So, chorea can be a late manifestation. Treatment is by using phenobarbital, and the second line drug is your haloperidol. The fifth manifestation is a erythema marginatum, which is a characteristic clinical rash which is seen in acute rheumatic fever. It is seen in the early stages of rheumatic fever. Can you see here? You have an erythematous serpiginous rash with central clearing. Most commonly found on the trunk. So, you have an erythematous serpiginous rash with central clearing, most often found on the trunk. Okay. And not to mention, is the arthritis of rheumatic fever deforming? No, it is a non-deforming arthritis. Fine, this is a non-deforming arthritis. So, this is about your clinical features of acute rheumatic fever. Now, over the course of time, in your first episode of rheumatic fever, what do you treat them with? You treat them with benzathine penicillin as a single IM dose. But over the course of time, they can have recurrent episodes of acute pharyngitis, and every time they have recurrent episodes of acute pharyngitis, you have a higher risk of development of valvulitis, right? So, you have a higher risk of development of valvulitis. That is the reason why you need to prevent the occurrence of rheumatic heart disease. And more episodes of valvulitis, what will happen? You in turn have mitral stenosis, right? So, the most common valve which is involved after recurrent episodes of rheumatic fever is your mitral valve. So, that is the reason why you need to prevent. And how do you prevent rheumatic heart disease? There are different ways. One is your primordial prevention. That means you prevent the risk factors itself. You improve the standard of living. Okay, you improve the standard of living and you decrease poverty. Okay, so this is your primordial prevention for acute rheumatic fever. Then you have something called as the primary prevention. What is the primary prevention? In the primary prevention, what you do is that you have the established risk factors, but you prevent the development of rheumatic fever. That means what? You do get your pharyngitis. You do have your pharyngitis, but you treat it well. So, you treat your strep A pharyngitis with penicillin and you treat it so that it gets completely treated well. And there are no failure rates. You decrease the failure rates. Then, secondary treatment. Secondary treatment basically means that you prevent recurrence. There is already one episode of rheumatic fever that has happened you prevent the next episode by secondary prevention. So, injection benzathine penicillin every 21 days is given IM. Okay, you give injection benzathine penicillin every 21 days. If there is no carditis, you give them these injections up to 5 years after the first episode of rheumatic fever or up to the age of 18 years, whichever is longer. If there has been an episode of proven carditis, right? So, during the rheumatic fever episode, they have done an echo and they have shown presence of valvulitis, then you give it up to 10 years from the first episode, or you give it up to 21 years of age, whichever is longer. Okay, so that is about your secondary prevention of rheumatic fever. Now, tertiary prevention means that the rheumatic heart disease is already there. Rheumatic heart disease is already there, but you prevent your complications. So, you prevent your complications. So, how do you prevent the complications? You do a valvotomy or you do a surgery, right? Because the more you have a rheumatic mitral stenosis, more the complications. You can have atrial fibrillation, you can have strokes, so you can have pulmonary hypertension as well. So, you intervene on time. Do a valvotomy or do a surgery. Okay. So, that brings us to the end of our discussion on rheumatic fever. Thank you.